Hello and a very good evening, everyone. Welcome to a brand new session of our CMS series brought to you exclusively by DocPlexus and Center for Metabolic Surgery. This center, under the guidance of Dr. Raman Goel, consists of a comprehensive team of surgeons, physicians, dietitians, and psychologists to assist on weight loss surgeries. To all who follow this series, you must be aware that CMS series entails a series of discussions around different clinical aspects in relation to obesity. Now, for today, we have with us Dr. Tariq Patel, who would be talking about obesity and GERD, that is gastroesophageal reflux disease. Epidemiological studies strongly suggest that the prevalence of GERD is increasing, and the major contributing factor to this trend is the rising prevalence of obesity. This trend has been observed globally. So, to shed some light, we would now invite our speaker for today, Dr. Tariq Patel, consultant gastroenterologist, hepatologist, and endoscopist at Jaslok Hospital in Mumbai. Dr. Patel has over 2 decades of experience in the field of gastrointestinal illnesses. In India, he has treated several patients with gastrointestinal disorders, providing the finest possible medical care. He is also the member of several important medical organizations and has published many articles in national and international journals. His expertise includes esophageal variceal sclerotherapy and band litigation, endoscopic hemostasis of upper GI bleed, gastric and colonoid polyp removal, etc. So I would now want to welcome Dr. Patel again to talk to us about obesity and GERD. So over to you, Dr. Patel.
Is somewhere in between. The point here is that it is still very common, a very common disease even in our population. And as a general practitioner, I think at least about 15 to 20% of your patients will be coming with dyspepsia or gastroesophageal reflux disease. Mind you, the two are not the same, but GERD will remain an important symptom for patient presentation in general practice. Now, what are the risk factors for GERD? Now, these are the risk factors. We all know hiatus hernia. Then important is obesity or overweight. Then we know certain food, high fat containing food causes, tobacco smoking causes, alcohol. Helicobacter pylori has an inverse relationship. Means if a patient has H. pylori infection, he is less likely to have reflux disease. And I'll tell you why. Because H. pylori infection leads to gastric atrophy. And once you have gastric atrophy, you have less amount of acid coming into the stomach and therefore less amount of acid refluxing into the esophagus. So there is an inverse relationship between H. pylori infection and gastroesophageal reflux disease. Then we all know pregnancy and genetic factors. Now let's come to obesity. Now, obesity, overweight is a common health issue in the United States and it is increasing. It is increasing in India as well. The US data suggests that about 35.5% of men and about an equal number of women are obese or overweight in the United States. And what about the data from India? If you see the Indian data, we have the ICMR data for 2015, and they have had a wide variation again, 11.8 to 31.3. And as you would, and it is basically for both, for just high BMI and also for central obesity. Now, this wide variation depends a lot on genetic factors as well as the eating habits of the population. Now, the obesity is probably the least in East India, regions like Orissa and all, and it is estimated to be highest in North India, Punjab, and even Western India, like Maharashtra and Bombay. So obesity is increasing in our population. That is, I think it is an indirect index of increasing or changing lifestyle or a more westernized lifestyle, a more sedentary lifestyle, and rising income of the population. So now, what is the evidence that higher BMI or overweight leads to an increased incidence of reflux disease? So most of the evidence what we have is based on epidemiological studies. Now, epidemiological studies are population studies where you study the population, and as the trend, as the weight in the average weight in the population increases, you see whether there is an increasing incidence of gastroesophageal reflux disease. And we have a number of studies from USA which have demonstrated that increasing level of obesity is associated with a greater likelihood of GERD and esophagitis. Okay, so not only symptomatic GERD, but you also have erosive esophagitis or you have associated mucosal damage. And these are some of the studies I've listed here. Now, besides epidemiological studies, we also have cohort studies which have looked at this relationship between obesity and GERD. And even in these cohort studies, it has been established that obesity is a risk factor for initial development of GERD as well as the persistence of symptoms of GERD. And this increasing BMI, it is associated independently of diet and energy expenditure. So by itself, a rising BMI is a risk factor for gastroesophageal reflux disease. And let's look what is the effect of change on which increase in weight on GERD symptoms. And it has been estimated that an increase of BMI of 3.5 kilogram per meter square when compared to no weight change is associated with an increased risk of frequent symptoms of reflux disease. So there is, based on this epidemiological studies and this cohort studies, there is a strong evidence that increase is associated with the rising incidence of gastroesophageal reflux disease. But all is not so rosy. Some studies have failed to establish a relationship between GERD and obesity. There's a Swedish study which is published in 2005, which showed that those who had been overweight or obese had an adjusted off ratio of 0.99, which means it is the same as a person who is non-obese, and they found no obesity and no increase in GERD in those who are obese. Similarly, we have a study from USA, Minnesota, where also they failed to find an association between weight loss and reduction in symptoms of GERD. So there are some studies which have not shown this association between rising body mass index and GERD, but by far, most of the studies have shown a strong link between rising body mass index and gastroesophageal reflux disease. So to summarize, the preponderance of population-based studies support the association between obesity and gastroesophageal reflux disease. The association has been demonstrated in USA, Europe, and even in Asia. Now let's look at this chart. This is easy to understand. It shows you the prevalence of obesity, which is color-coded, and in the numbers you have the incidence of GERD. So as you see, as the incidence of obesity rises, the incidence of GERD in the population rises. So where you have the highest incidence or the data available, say in USA, where the incidence of obesity is more than 30%, GERD is estimated to be at about 20%. And when you have obesity, say in India, this study has shown an obesity, this thing of 5 to 9%. And here the incidence of gastroesophageal reflux disease has been shown to be 7.6%. So rising body mass index is associated with rising incidence of gastroesophageal reflux disease. Now, reflux esophagitis associated with GERD is not just a benign disease. You have a higher incidence of complications of reflux esophagitis. You have erosive esophagitis is more common in obese. Not just that, Barrett's esophagus is also more common in obese who have reflux esophagitis, and Barrett's esophagus and adenocarcinoma is not then far behind. So we know that Barrett's is a risk factor for adenocarcinoma, and with rising incidence of Barrett esophagus, you have rising incidence of adenocarcinoma. So obesity-associated reflux disease is associated with worse outcome in terms of erosive esophagitis, Barrett's esophagus, and the incidence of esophageal adenocarcinoma. And here, abdominal obesity, truncal obesity or abdominal obesity has been shown to be a more specific risk factor for Barrett's esophagus. On the other hand, when you have, so that would be more like a apple-shaped body. And when the obesity is more in the buttocks, gluteal or femoral region, it is thought to be protective. And why does obesity lead to increasing reflux of GERD? I'll come to it. Here again, not all studies have shown an association between obesity and Barrett's esophagitis. Barrett's esophagus, we have an Australian study which was negative. They showed that BMI was not an independent risk factor for Barrett's esophagus. Similarly, we have a study from Canada which did not show an association between obesity and Barrett's esophagus. However, they did find an association between rising BMI with esophageal adenocarcinoma. So all in all, obesity not only leads to higher incidence of reflux esophagitis, it is also associated with complications of reflux esophagitis and a higher incidence of adenocarcinoma of the esophagus. And there is an association between increasing BMI and esophageal cancer, and it is specifically among younger, non-smoking individuals. Now, what is the pathophysiology? How does obesity lead to a higher incidence of reflux disease? Let's look at the pathophysiology. Now, to understand the pathophysiology, we have to know what is the normal physiology. What protective mechanism nature has provided us with to prevent reflux esophagitis. Now you have the lower esophageal junctions, lower esophageal sphincter, which opens or relaxes only when we swallow food to let the bolus pass through. And once the bolus is inside the stomach, this lower esophageal sphincter closes. So you have the internal sphincter, which is normally tonically closed, and it opens only in response to a swallow. Now this is augmented by the external lower esophageal sphincter, it is called, or it is basically the crural diaphragm. The diaphragm has a pinch-like action on the lower esophageal sphincter to prevent reflux from the stomach back into the esophagus. This is further strengthened by the phrenico-esophageal ligament. All right. So you have a number of factors working to prevent reflux of gastric contents back into the esophagus. So reflux will occur when one of these factors or a combination of this factor fail to prevent reflux of gastric contents into the esophagus. Now, what happens in obesity? Now, obesity will increase the intra-abdominal pressure. Now, this will occur because of increase in the adipose tissue of fat in the abdomen, or just say a simple fatty liver. It will increase the pressure inside the abdomen. Now, this increasing pressure in the abdomen overwhelms the protective mechanism by which reflux is prevented, and the patient ends up with reflux disease. And then what is the pathophysiology? There are other abnormalities occurring in obesity. Now, if you look, the basic problem is that there is prolonged esophageal acid exposure, okay? And it occurs more often in patients who are severely obese, which means having a BMI of more than 35. And this increasing BMI leads to non-specific motility changes in the esophagus. So there is decreased clearance of acid, which comes back into the esophagus. Then you have hypercontractions, which are non-propagative in the esophagus, which is known as nutcracker esophagus. And together you have the normal lower esophageal sphincter, which is closed to prevent reflux of gastric content into the esophagus, becomes hypotensive, permitting gastric contents to come back into the esophagus. And there is a very strong inverse relationship between BMI and lower esophageal sphincter pressure with a PR less than 0.001, meaning as the BMI increases, the lower esophageal sphincter becomes more and more hypotensive. So as BMI increases, the risk for reflux esophagitis is going to progressively increase. Now, another important mechanism which I failed to mention earlier in the genesis of reflux is what is known as transient lower esophageal sphincter relaxation. I mentioned earlier that the lower esophageal sphincter is normally tonically closed and it opens only during swallow. But you also have small, brief periods when the lower esophageal sphincter relaxes. That is known as transient lower esophageal sphincter relaxation. And this occurs, it's a kind of a venting mechanism nature has provided. So whatever gas we take with our meals and which accumulates in the stomach, now, this transient lower esophageal sphincter relaxation provides a means by which this excess gas from the stomach can be thrown out of the body. Now, what happens in patients who are obese? This incidence of transient lower esophageal sphincter relaxation is increased. So there are increased number of transient lower esophageal sphincter relaxation, and now this is an opportunity for gastric contents to come back into the esophagus. So we have a number of mechanisms working. We have a lower esophageal sphincter pressure, which permits gastric contents to come back into the esophagus. You have an increasing number of transient lower esophageal sphincter relaxation, which gives again a greater opportunity for gastric contents to come back into the esophagus. Now, the esophagus itself, which is supposed to push acid back into the stomach, does not function well, leading to acid staying back into the esophagus and leading to esophageal mucosal injury. And why esophageal mucosal injury will occur? Because the esophageal mucosa is a squamous mucosa. It is not like the stomach mucosa. It was not made to withstand so much acid exposure. So it gets damaged and you end up with having reflux esophagitis or esophageal mucosal tear, breaks or injuries. Now, hiatus hernia is also associated with obesity. Now, obese patients have a pressure gradient along the gastroesophageal gastric junction that supports the development of a hiatus hernia, meaning there is so much pressure from the abdomen that it is pushing the stomach up back into the thorax and leading to the formation of a hiatus hernia. And patients with hiatus hernia are more likely to have esophagitis compared to those without an hiatus hernia. So basically, not only hiatus hernia, it disrupts the normal gastroesophageal junction. The hiatal hernia sac itself becomes a reservoir for acid which has refluxed up, and then whatever residual acid stays in the hiatus hernia keeps repeatedly refluxing back into the esophagus and leading to prolonged acid exposure of the esophagus. Together, we were at the esophagus. Now, the stomach is also to be blamed because obese patients have normally a huge gastric capacity. So the gastric capacity is increased. So they have higher gastric contents in these patients. Together, they also have delayed gastric emptying. So not only do they have a big stomach, they have a stomach which is pumping slowly, so it has more contents in it. And so when reflux occurs, there is so much more to reflux back into the esophagus. And this delayed gastric emptying is due to neuronal and humoral mechanism. So there are a number of factors working in an obese patient or predisposing him to develop gastroesophageal reflux disease. Now let us briefly see what all is happening. You have because of the obesity, increase in intragastric pressure, and not just increase in intragastric pressure, as we just mentioned, we have increase in intragastric contents because of delayed gastric emptying. So there is so much here which can come up. Then you have the hiatus hernia forming here. So that has disrupted the gastroesophageal junction. So acid which reflux here can stay here, and from here it can keep refluxing back into the esophagus. Then we have, that the lower esophageal sphincter pressure is low in obese patients. So it like becomes one cavity from year to year for acid to keep refluxing. We also saw that there is an increasing incidence of transient lower esophageal sphincter relaxation, which also increasingly permits gastric contents to come back into the esophagus. And we also saw that the esophagus itself, the esophageal peristalses are impaired, so that prevents whatever acid which refluxes into the esophagus to be pushed back again into the stomach, so leading to prolonged acid exposure of the esophagus. Now there is something else. Now we just said there is now what all we discussed so far was say more mechanical and more chemical, but there is also some biology involved as to why these patients have worse outcomes or they end up with esophageal neoplasia. And that can be explained because of the secretion of adipokines, which are adiponectin and leptins. So what are adipokines? The fat cells in our body are not inert fat cells. They are not just storage for, say, fat that excess fat that the body has. Now, they are biologically active. They keep producing hormones. And the two hormones mainly they produce, which is known as adiponectin and leptin. Now, adiponectin is a protein which has anti-inflammatory action and immunomodulatory action. Okay, so it has a protective function in the body. And what happens, unfortunately, adiponectin is decreased with obesity. So the good hormone which the adipocyte secretes, that goes down, and the bad hormone which the adipose tissue secretes, which is leptin, that increases. So this leptin level directly rises with obesity, and leptin is secreted by adipocytes and gastric chief cells and has been shown to have mitogenic properties, meaning it is pro-cancer, it is cancerogenic, it has cancerogenic properties, and it induces proliferation. It makes the cell proliferate in a number of human cell lines, including the esophageal cancer cells. So you have the protective hormone going down and the bad hormone going up and predisposing the patient to neoplasia. So this is just a pictorial representation. You have rising levels of leptin, and we also have an increased level of TNF alpha. Now, TNF alpha, as you know, is a very strong pro-inflammatory cytokines. That also since it rises, you have a more strong inflammatory response in the esophagus, and you have the protective hormone, the adiponectin, going down. So there is an imbalance between the two, and this is one of the main reason why there is an increasing incidence of adenocarcinoma in patients who are obese and have associated reflux esophagitis. Now, let me just briefly tell you about weight loss and GERD. Now, since I spoke so much that weight increase or rising weight leads to GERD, does weight loss, it seems logical that does weight loss lead to a reduction in the incidence of GERD? So weight loss is dose dependently associated with a reduction of symptoms. The higher the weight a person loses, the more likely he is to recover from GERD or have a decreasing incidence of reflux esophagitis. There is, again, everywhere we have some odd studies. There was this one study which showed that it did not benefit some patients who lost weight, but this is a one-off study. By and large, the literature supports that with increasing weight loss, there is a decreasing incidence of GERD. Bariatric surgery and GERD, Dr. Goyal is going to talk about it, and he's an expert on that, so I'll not speak about it. But just suffice to say that surgical management has generally shown that this weight loss can have positive effect on GERD. To summarize my talk, epidemiological studies strongly suggest an association and an increasing prevalence of GERD and obesity. So, excuse this spelling mistake. Central obesity, as opposed to BMI, appears to be a better marker for the risk of metaplasia and neoplastic complications of GERD. Visceral adipose tissue secretes hormonal mediators which may increase the risk of Barrett's and esophageal adenocarcinoma. We just discussed leptins and adiponectins. Weight loss is associated with decrease in GERD symptoms, and bariatric surgery, we leave it to Dr. Goyal to discuss it. Thank you so much.
Thank you so much, sir. Very well presented. I think we have a couple of questions for you. So if we can go ahead with those.
Yeah, go ahead.
Sir, could you stop the screen share? So
yeah. Okay.
Yeah. So, sir, my first question is, could you explain the association of estrogen with GERD?
Good questions. Now, the best this thing is, you can see is pregnancy. In pregnancy, you have an increasing incidence of reflux disease. And for this, there are two mechanisms, like we discussed earlier also. So one you have is a purely mechanical mechanism by which the increasing abdominal pressure overwhelms the gastroesophageal sphincter pressure and leads to reflux esophagitis. On the other hand, rising estrogen levels also lead to a decrease in lower esophageal sphincter pressure and the increasing incidence of GERD.
Sure, sir. My second question is, how important is lifestyle modification for treating GERD? And what are your tips on lifestyle modification for patients with GERD?
Yeah, actually, lifestyle modification is very important. In this, there are two lifestyle modifications which have shown a definite positive effect. One is weight loss. Okay. If you take away, there's one or two odd studies which have not shown a relation. By and large, weight loss is associated with a decreasing incidence of GERD. So weight loss is primary. Other thing which has been definitely shown to increase or reduce the incidence of reflux esophagitis is elevation of the head end of the bed. So say about elevating the head end of the bed by about 30 to 45 degrees decreases the incidence of GERD. This does not happen by taking more pillows. You have to increase the head end of the bed. So these two have been positively shown to be associated with the reducing incidence of GERD. There are other things which are also very important and which we see in practice, and that one of the most important is fatty food. So oil, fat, butter in the diet. Increasing oil, increasing fat, increasing butter in the diet, there will be a higher incidence of reflux esophagitis. Then chocolates are associated with higher incidence of reflux. Lying down immediately after meals, ideally 3 hours, minimum 2 hours. There should be a gap of 2 hours between eating and lying down. Aerated drinks, like all aerated fizzy drinks, are more likely to cause reflux esophagitis. Wearing tight clothes is more likely to cause reflux esophagitis. So these things have to be generally kept in mind.
So, sir, since we are talking about lifestyle modifications, any specific lifestyle modification that you focus when it comes to pregnant women as patients?
Pregnant women have to follow all of these. There's nothing most interesting for this. Now, they have to have a gap between eating and lying down. They cannot just eat and lie down because it will predispose them to more GERD. They have to decrease the oil, fat, or butter content in their diet, avoid fizzy drinks, avoid chocolates. So basically, everything that you tell to a normal person will apply to a pregnant lady as well.
So one last question. This is from Dr. Begani. He says, what proportion of obese people suffer from GERD globally, and does it depend on the race or culture background?
I think if Dr. Begani maybe joined late, but I've shown in my slide that with an increasing, there was one slide which showed that, say in USA, when the incidence of obesity is about 35%, the incidence of GERD was about 20%. Okay. Similarly, in India, in that one study where the incidence of obesity was 11%, the incidence of GERD was about 7.5%. So epidemiological studies suggest that there is a strong correlation between increasing BMI and increasing incidence of GERD. So depending on the incidence of obesity, you'll have the incidence of GERD in that population.
Sure, sir. I think, sir, these were all the questions. I think, Dr. Raman, if you have any questions for sir.
Yeah, Dr. Patel, thank you. That was excellent talk because, not many people realize how important GERD is and its correlation with obesity. One question from my side. Just like obesity, all these lifestyle issues that we discuss are actually not implemented by patients, most of them. And thus the weight keeps coming back, or it's difficult to lose weight in long run.
True.
How do you see this happening in terms of GERD? Do people follow what you are saying, or does the GERD gradually worsens over a period of time?
You rightly pointed out that you tell patients to lose weight. A lot depends on the individual, and a lot depends on how well he's motivated. But as a rule of the thumb, initially people are very enthusiastic about it. They're very enthusiastically, they'll follow your diet, they'll follow whatever exercise regime you suggest to them. But usually these diet and exercise regimes are not sustainable. If you tell a guy that you go and say jog or do a brisk walk for 30 minutes a day, he'll do it, say, for a month, 2 months, 3 months, but generally over time, fatigue sets in and they give up. So if you have to tell the same patient, if you tell him, okay, you staying on the 5th floor, so rather than taking the lift or the elevator, you walk those stairs every day. That's something which is more likely to stay. So if your patient is motivated and you think he can do it, it's better to give him such advice which is likely to follow or stay with. Or if he's going to work, and if his work, his office and work is, say, about half an hour brisk walk. So if you tell them those advice, those are more likely to stay with the patient. On the other hand, if you tell them to go and jog half an hour every day, they all do it initially and then they give up. So it's something which is, unless you personalize it, individualize it for that patient, it does not become sustainable. And the same goes for diet. Initially, patients are very enthusiastic about that. They lose weight. But as you also know, in your first patient, there is a relapse and most of them regain the weight loss. So in fact, diet is more difficult to follow on a long term than exercise.
Okay. Dr. Patel, one more question, because, a lot of patients now, because of the Google knowledge, ask this question about antacids, chronic use of antacids. So since your GERD patients have the chronic symptoms and they are always put on medication because, lifestyle changes are ultimately not implemented by most patients, are the fears real about long-term use of antacids?
See, antacid, why people use it? Because it is available over the counter. it gives immediate relief. That is the biggest advantage with antacid, which is not provided by, say, a proton pump inhibitor. Patient takes antacid and immediately feels better. So it is good for those patients who have mild symptoms, who have intermittent symptoms, and say he has a reflux disease, reflux symptoms once in a week, it will work very well for him. So in those kind of patients who have mild symptoms and need to take antacids occasionally, it is good. The disadvantage with antacid is its action is short. Normally, it will not last. The action effect will not wear off, say, in about 2 hours' time. So patients who have very mild symptoms need to take it once a week or a couple of times a week. It can be easily prescribed and it is safe. But patients who need to take it more frequently and need to take it for a longer period, and especially magnesium trisilicate, aluminium, these have been associated with organ damage, and it is not good over a long time. There are other issues like some antacids are prone to cause diarrhea, some antacids are prone to cause constipation. So antacid, if taken in large volume over a long period, is not advisable. But however, taken once in a while for mild symptoms, it is a good therapy.
And proton pump inhibitors?
Proton pump inhibitors are excellent therapy. So normally the medical approach to GERD depends on how severe the patient's symptoms are. If the patient's symptoms are mild, we would advise a step-up approach. Means you start with antacids and then you can go to alginate or H2 receptor antagonists or proton pump inhibitors, depending on how severe the patient's symptoms are. But to begin with, if the patient has severe symptoms or he has failed mild therapy, or not just severe symptoms, you have done an endoscopy and you have found that he has severe esophagitis, then it is better to start with a top-down therapy. You start with the highest and the strongest, and once he has had some mucosal healing, then you can step down. So you have two approaches here. You have the step-up approach for those with mild symptoms, and you have a top-down approach with those with severe symptoms or mucosal complications.
Wonderful.
So proton pump inhibitors, again, we are coming, I think I skipped. Proton pump inhibitors are pro-drugs. They take time to act. On an average, they take about 72 hours for their maximum benefit to start, to achieve the maximum benefit. Then it is very important, since they are pro-drug and they act on the proton pumps, it has to be taken in an empty stomach, preferably in the morning, because that is the time when the maximum number of these proton pumps are there in the gastric mucosa. And there is a maximum opportunity for the drug to knock out those proton pumps. So it is important that it has to be taken in the morning before breakfast, 15 minutes to 30 minutes before breakfast. And it takes about 72 hours for its maximum effect to set in.
Okay. Thank you, Dr. Patel.
Thank you so much, Dr. Patel. I think one thing to take away would be to have sustainable efforts, even when it comes to diet and lifestyle modifications for any patient. Yeah. So thank you so much, sir. Moving on, we would have Dr. Raman Goel, Director of Pediatric Surgery at Cohort Hospital, Hinduja Hospital, Zen Hospital, etc., to shed some light on pediatric surgery and GERD. So, Dr. Goel, over to you, sir.
Yeah, thank you, Dr. Darshika. So I think my job has been made easy by Dr. Patel when he has spoken in detail about how obesity and GERD are interrelated. And of course, there are always an odd study to say that they are not, but everybody knows and there's enough data to support. And then he also mentioned that every 3.5 BMI increase, there is a substantial increase in GERD. What we see in our practice is most of the patients are 35, 40, 45 BMI. So in our own experience, we see almost 60 to 70% patients have symptoms of GERD. They may not be proven with GERD because most of them have not undergone an endoscopy in past. But in this population subset that comes to our OPD, the possibility of GERD is very high. And that is why the role of bariatric surgery, how it impacts GERD, is important. And I'll briefly talk about it in a few slides. So today I'm going to talk about what is the impact of bariatric surgery on GERD. And I bring greetings from Wockhardt Hospital, Mumbai. So as has been said by Dr. Patel, that the obesity is increasing worldwide. And because of obesity, there is a increasing obesity, there is an increasing acceptance of bariatric surgery as a treatment modality. Initially, bariatric surgery was offered only for weight loss, but gradually people have realized that it not only reduces weight, it helps in treatment of many comorbidity. Because as realization is settling in, just like how it was told before me, that GERD is not only a mechanical problem, it's also a hormonal problem. There are hormones which affect reflux. And so when we do a bariatric surgery, we are not treating only the mechanical part of it, we are also improving something like insulin resistance, we are improving the adipokines, and that is how the GERD is also improved in some of the bariatric surgeries. So it helps in preventing chronic conditions and even esophageal cancers. It's an established fact that the number of esophageal cancers reduce after a bariatric surgery. Now, we are aware that bariatric surgery has a variable response on GERD. Not every surgery gives the same kind of response. So we have seen, and there is published data to say that if patient undergoes sleeve gastrectomy, in some of the studies, the GERD has shown to have improved, but in a large number of studies, it has shown that GERD can worsen. And that is why the sleeve in presence of GERD is a questionable procedure. But with gastric bypass, the improvement is seen in most, very significant improvement. I mean, many studies show that the improvement is even better than the improvement seen in fundoplication in non-bariatric patients. So gastric bypass is actually therapeutic for GERD. So GERD, the presence of GERD in our practice works as a determinant of bariatric procedure. And there are studies to support this. So it's an important preoperative consideration for a patient who is planning to undergo a bariatric surgery. So American Society of GI Endoscopy in 2008 said that all patients who are going for bariatric surgery should undergo a pre-op upper GI endoscopy, primarily to exclude GERD, primarily to find out whether the patient has any other issue inside, like a hiatal hernia or a gist or an ulcer. And then there is another study which got published very recently in 2020, which says that patients who are planning to undergo bariatric surgery should be thoroughly investigated with 24-hour pH study and high-resolution manometry to select the most appropriate bariatric procedure. So GERD is, in our practice, the most important determinant because the weight loss and resolution of other comorbidities are almost similar between different procedures. But resolution of GERD is different between sleeve gastrectomy and gastric bypass, and that is probably the most important way to identify which procedure should be offered to patients. So going specifically to sleeve. Now, if the patient is a diagnosed GERD patient or patient has symptoms of GERD, we generally avoid a sleeve and instead offer a Roux-en-Y gastric bypass. So if patients have symptom of GERD, patients should be very thoroughly investigated with manometry, and only if it is normal, then we offer sleeve. Otherwise, we'll offer a gastric bypass. Patients where hiatal hernia is not diagnosed before surgery, and we find a hiatal hernia during surgery, incidentally diagnosed hiatal hernia, then there are two options. Either patient can be counseled in advance and we offer a gastric bypass, or there are studies which show that if we do a concomitant hiatal hernia repair, then possibility of post-operative GERD gets reduced and we can do a sleeve. Then it is also published that if patient has H. pylori before surgery, then its eradication helps in treatment of GERD after sleeve gastrectomy. So this is the way we manage patients who present with GERD, and are planning to have a sleeve gastrectomy if it is required. Now, what about GERD and gastric bypass? Now, there are again multiple studies to show, but as I said, gastric bypass is therapeutic for GERD. This particular study, which was published in 2002, 152 patients who already had GERD, and they were followed long term, and they had been seen that there is a significant decrease in GERD symptoms like heartburn, water breath, wheezing, laryngitis, and aspiration. And not only the symptoms improved, accordingly, the medicine used also dropped significantly for both PPI and H2 blockers. Another study, which had 57 patients with preoperative GERD, at 18 months, it showed there was a clinical improvement in all patients, or there were no symptoms of GERD in these patients. So when it comes to GERD, gastric bypass is the procedure of choice, because it not only helps in losing weight, it treats the person of GERD. So friends, the take-home messages are simple. GERD is common comorbidity of obesity. As I said initially, in our patient subset, almost 60 to 70% patients present with GERD. And that is why now we are offering gastric bypass in almost 70 to 80% patients, because we do not want to have patients with worsening GERD after a sleeve gastrectomy. Bariatric patients should be evaluated closely for suitable procedure before surgery. There is significant improvements seen in Roux-en-Y gastric bypass. And patients who are going for sleeve gastrectomy, it's a good idea to do a H. pylori eradication in advance. And if they are found to have incidental hiatal hernia, it should be repaired at the same time. Moving beyond GERD, now just to summarize, bariatric is accepted for cashless treatment by all insurance companies, and almost 80% of the patients who are now coming to us are getting it done through cashless route. And there are very definite guidelines which a family physician should know, that if BMI is more than 40, that means if patient is 41, 42, or whatever BMI, then you don't need to prove that they have any other disease. Obesity itself is accepted by insurance companies as a disease, and they will approve a cashless payment. But if they are less than 40 BMI, then it's only payable if they are between 35 to 40 BMI with one of the 4 comorbidities. Only these 4 comorbidities. Either a cardiomyopathy, or if patient has coronary heart disease, that means patient had a stent or a bypass in past, or if the sleep study shows apnea hypopnea index of more than 15, that is severe sleep apnea, or if patient is uncontrolled type 2 diabetes. So the leeway is between 35 to 40 BMI for patients with one of these 4 diseases, and then insurance cannot refuse treatment of these patients. So thank you so much for patient listening. I'll be very happy to take a phone call, any questions. And thank you, Dr. Darshika.
Thank you so much, sir. We do have a couple of questions.
Sure.
So my first question is, the literature suggests that different surgeries have different impacts on symptomatology of GERD. And
Yes.
What is your opinion on this, and how to reach a conclusion about optimal surgery for the patient? I think you've already talked about it, but if you want to highlight it.
Yeah, so I think what has happened, Dr. Darshika, is that we all learn with time, the evidence gets generated. So somewhere about 2004, we started doing sleeve gastrectomy in the country. Bariatric we were doing from 2000. And first 7-8 years, the sleeve being a simpler procedure, almost 70-80% procedures were sleeve gastrectomy. But somewhere in 2014, first publication came out which said that sleeve gastrectomy is causing more reflux. And that is when we also took notice that our patients are also coming back with symptoms of reflux. And gradually we are now very particular, as you are rightly saying, that the different procedures have different symptoms. So anybody who has a proven GERD or even remote symptom of GERD, because patients try to underplay their symptoms. They say because they know if they go to Dr. Goyal and if they say they have acidity, they will get bypass. So they try to avoid getting a bypass by underplaying their symptoms. But if they underplay their symptoms, we definitely get their endoscopy done, maybe manometry done, any which way to find out whether they have GERD or GERD-related disease. And if they have it, we discourage them to have a sleeve gastrectomy. And now this is almost a worldwide acceptable proposal that patients with GERD should not be offered sleeve gastrectomy. So it's a difficult situation to be, because we have been doing these surgeries, but this is how the medical learning happens, by the data that gets generated. But bypass treats symptoms very early. So all these patients who undergo bypass, majority of them, 90-95% of them, will not require antacids or PPIs or H2 blockers in long run. Few of them who have a like a peristaltic disorder or motility disorder may need it for that particular purpose, but not otherwise. So if these patients are properly worked up, we can actually anticipate in advance that which of these patients, hardly 5-10% of them, will require medication in long run, but otherwise 90% of them will improve.
Sure, sir. Thank you so much. One more question. When and how should a physician conclude that a patient would require surgical intervention, which is a bariatric surgery, and he would benefit from it? So where do we draw that line, or how do we conclude on that?
Okay. So it's very simple. A patient who is suffering with obesity and has comorbidity. So generally patients decide now, physicians don't decide. Physicians supplement their desire with scientific knowledge. This is why these programs are, that we share scientific knowledge, the data, as Dr. Patel has shown, as I have shown, so that they are updated in their knowledge about a particular comorbidity. So if patient has been taking, let's stick to GERD, if patient has been going to a gastroenterologist or their family physician for years, and symptoms are gradually worsening, any which way, either because they are not able to maintain the lifestyle, or they are not able to take medicines on a regular basis, or even with medicine symptoms do not improve, then it's a good time to choose. Then comes the BMI criteria, that they must fit into the BMI criteria. So in India, the BMI criteria are 37.5 without comorbidity, and with comorbidity 30 BMI. So if somebody is 30 BMI and has GERD, we can offer surgery. So ultimately, it is a matter of patience, how long they are able to sustain with medication. Many of them are able to change their lifestyle, and they are able to avoid a surgery. Surgery is one of the options. It cannot be the only option. The first option is lifestyle treatment. Second option is medication. And if both these don't work or not able to deliver, then surgery is the third option.
Thank you, sir. Dr. Patel, you have any questions for Dr. Goel here?
No.
Okay.
Yeah.
Sir, these were the questions I had. I would now like to invite our patient for today, who is Mrs. Smita Darte. Ma'am. Mrs. Smita, if you could switch on your video.
स्मिता जी हमारी बहुत पुरानी पेशेंट हैं और इनको रिफ्लक्स की प्रॉब्लम थी, इन्होंने बेरियाट्रिक कराई. स्मिता जी, आप अपना वीडियो चालू कर लीजिए, कैमरा चालू कर लीजिए. स्मिता, आप हैं इधर प्रोग्राम में? Shithil, maybe you can try to call her up and see. Yeah.
It's okay. I think we'll wait for 2 minutes.
Yeah, sure.
So, but I think the point that you discussed about over-the-counter pills, antacids, I think that is very prevalent especially in a country like India, where it's very easy to get antacids, and people do rely on those, and they want to sort of not go to the doctor and take the medicines themselves. So I think we've seen that practice very often.
And Dr. Patel, I can add something in this. You know, the PPIs, there is a apprehension about calcium absorption and all. So how real are those issues? That is the thing.
There were some. Now, as we know, for calcium to be absorbed, you need acid. And when you knock out the acid from the stomach, the calcium absorption may suffer. And there were some publications that there is an increasing risk of fracture neck femur in ladies who are on long-term PPI. But after those initial publications, subsequent publications have failed to show an association between PPI and fracture of the neck of the femur. But nevertheless, that doubt still remains. And that's why even we would not like to advise PPI indefinitely. We normally, most of the time, would like to stop it after 8 weeks, unless the patient has say Barrett's esophagus, and only then you would put them on long-term PPI. Besides those fracture risk, I think what was more relevant to our population, in fact, when I was at KEM, my thesis topic was PPI and the effect it has on gut flora. Because as we know, acid is protective in the stomach and it knocks off many harmful bacteria which we ingest. And so whether knocking off the acids will lead to an increase in GI infection. So we demonstrated and we published that once you remove the gastric acid, that there is an increased number of bacteria forming colonies in the stomach. But surprisingly, from those, there were very few who actually developed symptoms. So although there was an increasing incidence of bacteria overgrowth in the stomach, symptoms were not few. But other studies subsequently have shown that there is a rising incidence of enteric infections, which are symptomatic. There is an increasing incidence specifically of pseudomembranous colitis in patients who are on PPI and who are critically ill. The point to take here, or the take-home message here would be that PPI is a drug. Use it judiciously. Don't just use it or misuse it as if it is, some chana batana. It's not to be done.
That's right. That's a good message. Yeah, thank
you so much, sir. I think Miss Smita is here. Smita ji, आप अपना वीडियो ऑन कर ले please.
I think आप उनसे क्वेश्चन पूछिए तो she will start.
ते व्हिडिओ हे केलाय झूम म्हणजे माझं ते काही कळत नाही मला त्याचं काय करायचं.
स्मिता जी, आप अपना वीडियो ऑन कर लीजिए.
हाँ वही करती हूँ वीडियो ऑन करें कसं करणार तुमची लिंक दाखवा.
या
हेलो स्मिता जी.
हाँ यहीच आहे वीडिओ ऑन हे करू म्यूट करायचं.
ठीक है दिख रहा है आपका जी.
म्यूट हो गया अभी. अनम्यूट करेंगे प्लीज. हाँ स्मिता जी, मेरे पास एक क्वेश्चन है आपके लिए. तो आपने क्या सिचुएशन में डिसाइड किया कि आप वेट लॉस सर्जरी के लिए जाएंगे?
नहीं, लेकिन मेरा ना वेट बढ़ रहा था. हिंदी में चलेगा ना बात करके? हाँ वेट बढ़ रहा था और मेरा ब्लड प्रेशर था, शुगर था, तो हे नंतर ये क्या आपला थायराइड था. इसलिए मैंने सजेशन करा. हमारे एक रिलेटिव है उसने भी कर दिया है, चारुल म्हणून, रमेश चालू. उनका भी वैसा ही वेट का प्रॉब्लम था तो उन्होंने किया तो उनको बहुत फायदा हुआ. इसलिए हमने उनका देख के मैंने कर दिया. लेकिन अभी मैंने वेट सर्जरी किया, वेट रमन गोयल ने किया. इसकी वजह से बहुत अच्छा हो गया, वेट भी कम हो गया है. सब ब्लड प्रेशर शुगर सब है. इसकी दवा भी मैं कुछ लेती नहीं हूँ, खाली वो सेंट्रम और ये दूसरा जो गोली है वही लेती हूँ बस. अभी अच्छा वेट भी कम हो गया, 72 हो गया है मेरा. पहले से 104 था
जी,
अभी 72 पे है आगे. अरे अच्छा लग रहा है मेरे को चलने की. नहीं तो मेरे को बाहर जाने के लिए तकलीफ होती, पाँव में बहुत दर्द था, ये सब हो रहा था. इसकी वजह से अभी पीडियाट्रिक सर्जरी के बाद बहुत अच्छा हो गया. अभी 3 साल हो जाएंगे ये 18 जनवरी को.
जी मैम. अब इससे आपको कोई फायदा हुआ आपके सोशल लाइफ में या आपकी निजी जिंदगी में कुछ इसकी वजह से आपको
अच्छा,
फायदा
तो
हुआ?
फायदा ही हुआ मेरे को, बाहर घूमने के लिए, चढ़ने के लिए। तो मैं थोड़ा इधर इधर 10 मिनट में चलती थी तो मेरे को कंटाला आता, पाँव में दर्द था, चलने को लिए नहीं होता था। थोड़ा जरा ऐसा मन में थोड़ा निराशा था, हम क्या कर नहीं सकते, खाना पीना भी थोड़ा ये नहीं खाने का, वेट बढ़ रहा है इसलिए, वो कहीं नहीं खाना चाहिए, इसलिए कोई खाना कम करने से तो कुछ ये होता ही नहीं हो। इसलिए हमने सोच लिया कि नहीं चलो सर्जरी करेंगे, तो कर दिया, तो बहुत फायदा हुआ।
जी मैम। मैम एक और क्वेश्चन, आपको कोई अपने लाइफ में परिवर्तन किया आपने, मतलब क्या नहीं खा रहे, कोई चीजें को आप अवॉइड कर रहे हैं जिससे कि आप लॉन्ग रन में ये
नहीं, तो मीठा तो कुछ नहीं, शुगर ये कर दिया है। चाय भी जो पीती हूँ तो शुगर फ्री के पीती हूँ, हमेशा प्रोटीन कभी भी स्किप नहीं करती हूँ। इसकी वजह से मेरा खाना भी थोड़ा मुझे चलता है, अच्छा हो गया है मेरे लिए। थोड़ा खाना भी कम करती है, आधा चपाती खा सकती हूँ मैं, पर लेकिन प्रोटीन शेक मैं अवॉइड नहीं करती, रोज लेती हूँ हमेशा।
जी मैम।
वो तो अवॉइड नहीं करना ही चाहिए अपने के लिए।
डॉक्टर गोयल, यू हैव एनीथिंग टू से?
नहीं, मेरे हिसाब से स्मिता जी बहुत ही अच्छी फॉलो करती हैं, जैसा बोल रही हैं 3 साल बाद भी अभी भी ये प्रोटीन शेक रेगुलर लेती हैं। बहुत सारे यंगस्टर्स भी इतना रेगुलर फॉलो अप में नहीं होते, और उसी लिए आप देखिए कि इनका वेट लॉस इतना अच्छा हुआ है और मेंटेन भी कर रही हैं। तो आई थिंक जितनी भी ये लाइफ स्टाइल डिजीजेस हैं उनमें सर्जरी कैन गिव अ बिग पुश, बट अल्टीमेटली लाइफस्टाइल चेंज जो लोग करते हैं वो उसको बहुत अच्छी तरह मेंटेन करते हैं। स्मिता जी तो बहुत अच्छी तरह मेंटेन कर रही हैं। आपके डायबिटीज का क्या हुआ? डायबिटीज के लिए या आपको एसिडिटी तो नहीं थी?
दवा कुछ नहीं लेती, कुछ नहीं, पूरा सब ये हो गया है। खाली मैं थायराइड की लेती हूँ, और आपने हो जे दिया वही, बाकी कुछ नहीं लेती।
बाकी
बीपी का भी नहीं लेती हूँ, शुगर में इसका, डायबिटीज का भी कुछ नहीं है मेरा दवा। कंप्लीट बंद हो गया, 3 साल हो गए।
एक्सीलेंट।
शुगर भी मेंटेन है, वेट भी ये बढ़ता भी नहीं, कम नहीं, शुगर भी बराबर रहता है, 100 के अंदर ही रहता है, 95
आपको ऑपरेशन के पहले एसिडिटी तो नहीं थी?
नहीं, अभी भी नहीं है।
ओके, ऑलराइट। डॉक्टर दर्शिका।
ठीक है स्मिता जी, थैंक यू सो मच, आप आए और हमसे बात करी आज। So I think on this note, I would also like to thank Dr. Goel and Dr. Patel for your clinical insights on this topic. Of course, our patient for coming on the platform and talking to us. To our dear viewers, thank you so much for your support and interaction for today's session. We would be back with discussions around obesity management in our series. And until we see you again, please take care and have a great evening ahead. Thank you so much.
Thank you, Smita. Thank you,
Dr. Patel.
Thank you, Smita ji. Thanks, Dr. Darshika and Doc Plexus.